And it's actually a pleasure to be back to physical meetings after the plethora of webinars that were imposed upon us by the minuscule virus the past 2.5 years. And for that, I thank Vijay very much. Also, Tanay, Mansi, especially because it's always accompanied by very warm hospitality. So thank you for inviting me here. And I must acknowledge the contribution of my young colleague on the breast team, Dr. Ankit Shah. Now, it's well known to us that sentinel lymph node we reserved for early breast cancer standard of care for radiologically and clinically negative axilla. It involves removal of 2 to 4 sentinel nodes. We do a frozen section and perform an axillary dissection only if positive. Clearly, we know the disadvantages of doing an axillary dissection where it isn't warranted. The SLNB procedure is now well established, and the aim is to attempt to identify the first echelon lymph nodes to which metastatic spread would have occurred, pick them up and confirm. If so, then one would assume that there is micrometastasis to the higher echelon nodes, and then that would justify an axillary node dissection. And the way we do this is that we inject some tracer and follow the drainage pathway from the areola out into the axilla. The commonly used tracers are blue dye, radioactive colloid, usually technetium, and of late a lot of interest in the use of ICG.
Sorry, I think we skipped slide or two.
Long press on.
Yeah. So in comparison with radioactive colloid and blue dye, either individually or in combination, recent studies have clearly shown that ICG is non-inferior. In fact, this meta-analysis shows that it is superior. So it's perfectly acceptable to use ICG, and I think it makes it much easier for us to use ICG, and I'll come to that as we are running the video. But what it essentially does is that after injection, you have a near-infrared camera which will detect the pathway and guide you to the axillary sentinel node, which you pick up on the monitor. This is the machine that we are using. It's an indigenous machine, and the capital cost is much less than the imported machine. And we've been using it now for about 2.5 years, and we are quite happy with the results. This is the dye that we use, diluted, and we use a hypodermic syringe to inject. And the procedure involves injecting in the periareolar area and then opening up the axilla with a very small incision to take out the sentinel node. On the right, you can see the camera and the screen, and very small incision dissection takes place, and then you extract the node and submit it for frozen section. Now, the injection is a very important component of the entire technique, because a superficial injection will allow almost exclusive axillary drainage. Deeper injections will allow non-axillary drainage and will confound whatever it is that you're trying to see. So superficial injection is acceptable periareolar, preferably intradermal. And we usually inject at 2 points, that's 12 o'clock and 3 o'clock if it is the left breast, or 12 o'clock and 9 o'clock if it is the right breast. And you can see here the wheel coming up here that shows the intradermal volume. And the beauty of ICG is that it requires a very short time before you can actually start looking for the node. And I think this is one of its biggest advantages. Now, just show you what it looks like on the screen. This is the injected periareolar area. This is the draining lymphatic channel you can see going towards the axilla, this one. You do have to massage the areola and the breast very gently for a couple of minutes. That promotes a more rapid drainage and visualization. And then it remains for you to put an incision about 1.5 centimeters away from the end point of the draining lymphatic channel and open up just deep to the deep fascia, get into the axillary fat pad and pick up the node. You can see here it's illuminating beautifully. And usually this is, you need to have the OT lights off when you're doing this. So initially it was a bit of a challenge. We used to toggle between turning on and off the lights so that we could find our way, because you inevitably end up disrupting one or two vessels and the field will suddenly start welling up. But over a period of time, I think we are now used to operating with the light of the camera itself. And then of course, once you have the node out, you put it onto the gauze or the mop and confirm that it is truly the sentinel node and submit it to the pathologist for frozen section as individual nodes. It's much easier rather than to ask the pathologist to cut the specimen and then start looking for the nodes themselves. Now this shows the screen picture of the actual removal. One of the things that you need to be careful about is to try to identify draining lymphatic channels and clip them off before you go for the node. Otherwise, the entire field will get suffused with the spilt ICG, and then it's very difficult to identify individual nodes. So, and these are not difficult to see because these lymphatic channels after injection are quite large. I mean, I would hazard that they're about easily 4 or 5 millimeters, and you can see them and actually clip them off. And usually when you pull out the first node, you'll see maybe 1 or 2 adjoining nodes also, which I've illuminated, and you would pick that up along with the entire specimen that you're pulling out. And you see here, you will see that there is a lymphatic channel which will get clipped before we would cut it. That's clipped, and now you cut just in front of it so that there is no dye spillage. Once again, put it out, confirm that it is the node, cut it out, individual node, sent in separate containers to the pathologist for frozen section. Now this is the patient side picture, and you can see that you will see the dye being stained green, just like you do with the regular toluidine blue that we use if you're using a blue dye. And of course, in such a situation, you pretty well can turn off the camera and directly use the operating lights to excise the node. The other thing I can tell you from my personal experience is that you have to guard against taking out too much. We are so used to working in the axilla that it doesn't take us long to do an actual axillary, low axillary, sampling rather than a true sentinel node. The incisions are quite small, and we would put them into cosmetic lines. Usually when I'm doing an oncoplasty, I would have the entire area marked, all the lines marked, even though I may not actually use them in the oncoplasty, because this would aid me in putting the incision appropriately for the sentinel node. Otherwise, you would get somewhere else that really doesn't give the kind of cosmetics that you would desire. Now we've got used to having the camera at a specific distance away, so it allows the surgeon to work without
5
coming
minutes
in the
left.
way of, watching the field.
5 minutes left, sir. 5 minutes left.
This is a simultaneous view. You can see the draining channel here, and we are just locating it with the artery, and then we will just make a small mark there and mark it off. And then a 2-3 centimeter incision along the lateral crease. Now, I'm going to put this on simultaneously. You'll see the picture on the screen as well as in real time. This turned out to be quite a large node. We know that imaging cannot identify the exact number of lymph nodes accurately always. This turned out to be a fairly large node. I'll just skip that. We've already seen this. Now, this was a case where we had non-visualization. We injected and the tumor was about 2 centimeters away from the periareolar area, probably because of blockage of the lymphatics by tumor cells. Despite waiting a considerable amount of time, we couldn't see any drainage into the axilla. There was this solitary drainage going down towards the inframammary crease. So we've done over 100 SLNBs now, the majority being with breast oncoplasties, but 4% of cases where we did it with a mastectomy. The non-visualization rate is extremely low, 0.036%, and we converted to an axillary node dissection in 17% because of positive nodes on frozen section. The false negative rate was 0.018% and false positive 0.0009%. Thank you for your attention.
Thank you, sir. Such an excellent video. And any questions from audience or senior consultants?
Very good presentation, Raju. Only thing that probably I would make a small comment is that while injecting, one need to remember there is no spillage. Otherwise, it spoils the pickup of the camera because it stays on the skin pretty long, and you need to probably repaint everything and that kind of thing. Otherwise, it's fantastic. We have recently acquired ICG machine, and we are very happy about it. Thank you.
Dr. Rajiv, congratulations, wonderful video. One tip about the non-visualization. Sometimes I've seen one of the limitations of ICG is the depth of the node. ICG cannot pick up the fluorescence if it is more than 1.5 or 2 centimeters from the skin surface. So we have some techniques. What we have seen, if you just compress the whole skin back, sometimes you may get the node. The second technique is you have shown the lymphatic, it just gone somewhere and stopped there. So you point that, start dissection gently, and you bring back the camera again. After you go a little deeper, you can find the node sometimes. So these are few tips, yeah, because of the depth limitation. So even we face the similar issues. And the injection is again very, very critical. As you said rightly, intradermal gives the best outcomes. Small volume, intradermal. Absolutely. Thank you.
Yeah, I completely agree with you. Now the only pitfall of ICG is the thickness of the transdermal fat. And I remember one of the publications which states if the BMI is more than 36 or 38, then the sensitivity goes down. And therefore, the current recommendation based on the meta-analysis is that it has to be combined with a blue dye, or else ICG is fantastic. I am actually addicted to this technology. It's fantastic.
Raju, you showed the combination of dye and the ICG. My question is, many times you use the blue dye. There are few nodes which is not picking up those blue light. Will you leave behind, or you will take them up and send it for frozen section? Blue dye, you see one node picking up the blue dye, remaining 3 nodes will be remaining there. Will you pick up those nodes or send it or not? Pardon? We do that because I have seen many times we are analyzing our own data. Some of those which are not picked up by blue dye, they became more positive rather than the blue dye which is picked up which came negative. So there are some of these common things we see. So the blue dye is one of the wonderful drugs in the peripheral parts of the country where there is no need for any other fantastic things. These are the few things you should be remember. Many times when you pick up those nodes, you know that your pathology say you have picked up 10 to 12 nodes. It is almost equivalent to axillary dissection.
Rajiv, one question. If you are working in a situation where you get all the 3 facilities, technetium, blue dye and ICG.
I would still use ICG.
You will go for blue dye.
Because it's cumbersome to use a radioactive colloid.
Yeah, exactly.
Blue dye alone
So for the students,
So, apart from the minimal radiation that you are going to be giving, it's cumbersome. The actual technique, sending the patient over, marking, bringing back, checking. We started with ICG because we didn't have access to the radioactive colloid, and it's worked very well.
Sir, a single question. Do you consider multifocality as a sort of relative contraindication to performing sentinel lymph node dissection? And your experience with intradermal ICG injection related skin necrosis compared to blue dye?
This we normally see with methylene blue.
Yeah.
If it is intradermal, ICG and isosulfone blue are quite safe.
And earlier years, nearly 15-20 years ago, we used to inject the blue dye into the tumor tissue. Once the technique has been changed, incidence of skin necrosis and all the problems have reduced.